Madeline, Muller, who's known to all of you, is a family physician and senior lecturer at Walter Sisulu and working at Cecilia Makwani in East London. She's on the Rudasa exec, as you know. And she's going to present on the rural onboarding, which you might have heard a little bit about, but we're looking forward to more detail, Madeline. Thank you.
Hi, everybody. Thank you very much. It's really fun to come and present on what is really a Rudasa baby, something that's been created by rural clinicians for rural clinicians and came out of, I think, the many rural conferences. And I think every single rural conference I've ever been to, we have talked about the poor ComServes arriving in the rural hospitals and part of retention strategies, burnout prevention, but just generally, how do we help and looking at lots of facets of looking after rural doctors. And then the one issue was just an in-service program. How can we in-service rural doctors when they arrive in a rural facility? And then over the years, we have tried various things, and it never worked because you were right at the beginning of the year and you've got all these, you know, like in Eastern Cape, you'll have 2 ComServes here and 2 ComServes there and 2 ComServes there. You can't take them out for a week. You can't transport them. You have to accommodate them. Every now and then the DOH would sponsor a little thing and then the next year it wouldn't happen. And then we didn't, Jenny and I remember on the airplane, where would we have gone? I think Henley on Clip. We were discussing this thing of we should just do something, even if it's just a one day. And so in February of 2020, we did a one day in Clinsta in East London, sort of looking at ComServes in the Eastern Cape. I think we managed to get a whole 30 people, which felt very profound, but it's not that much in terms of the amount of doctors that actually need care. And then COVID happened literally a month later and transformed rural networking and rural education. And it's actually been extraordinary to see how the world of education has been changed by the COVID epidemic, and suddenly Zoom and Microsoft Teams, which was not just the select, you know, techie kid that had access to it, but every single doctor can access a Zoom or a Teams presentation. So the next year, when we were right in the midst of everything, we decided, well, let's then do an online program, which was the rural onboarding. And we just piloted it in the Eastern Cape. We did it over 6 weeks. It was very popular. And so this year we decided, let's go national. And I'm just going to tell you a little bit what that looked like and now what we want to build that into. So what do we mean with rural onboarding for those of you who still not knowing the details? So it's a 6 weeks orientation program, and it's actually a roadmap. So it's not like a course that you do on the Knowledge Hub, for example. It's literally, we just give you a bunch of stuff and you decide how much you want to engage with it. So it's open to all new rural health clinicians. That was the plan, but we have found, you will see that lots of people were very keen to join. The content at the moment is mostly focusing on doctors and clinical associations, but the vision has always been much broader. It just depends on who puts the effort in. It's fully online distance learning, so no doctor had to travel. And what was amazing is, to put it together, it was basically a huge amount of people that contributed in various ways. As senior clinicians, experts, Rudasa people who would give input on what we should put in and was doing the webinars. And all of this was freely offered. It was quite amazing. We never had a discussion on, you know, is there, everybody was just happy to contribute. And therefore we set the whole thing up with absolutely no cost. It didn't cost us anything to set it up. We were just using our own academic time, so to speak. We could make it free I just uploaded stuff onto YouTube. You have all these free platforms. And so apart from the Zoom license, which we already had, there was no other costs involved, which is very nice. So we had 183 clinicians that signed up this year. We mainly advertised through our own databases, which is why there's such a big Eastern Cape representation, because it's a little bit on who knew about it. And you can see, although we were targeting ComServes, there were 72 ComServes that joined, but there were 65 medical officers. And then we had some academics. We even had some consultants that was joining. Sometimes we had a consultant from Botswana who was just keen to have access to the materials to then use and share with his own teams. So it was Lots of different levels. We had some interns as well, and you can see some non-doctors. We encouraged non-doctors to join, but we did know that the content was quite doctor heavy. But there were some topics around public sector, thriving in rural healthcare, etc., that was more applicable to the different cadres. So this was the province, the province representation. You can see we had 54 from the Eastern Cape. So KZN, Gauteng, even Limpopo, well represented Western Cape. And then we've just had the Free State and the Northern Cape. And this, I think, has to do with marketing. It literally has to know who knows about the course. So our marketing was not very intelligent. It was very much opportunistic. So the big thing was to forge this curriculum. So we had this plan. We're going to give young rural doctors a roadmap. So what do you put in? And the problem was not really what you put in, it was what do you leave out, right? Because there's everything to cover. So you have to have a little bit of faith that they actually have had medical school and they have had internship and they have hopefully covered quite a lot of stuff. So what do you choose to now actually put into your curriculum? And we used an informal expert consensus process. It's not in any academic journals. And it would be lovely to do a proper Delphi on this, for example. So I've got a great registrar at the moment doing a Delphi process on what you put in an ultrasound course for district hospitals. And so if there's any registrars looking for a cool MMed topic, but we just literally invited. So I sent out to all my buddies, Radasa and the different universities, and asked them if they would be willing to serve on a informal faculty. We didn't actually meet. It was all done through emails, and different people have different strengths. So I consulted people like David Bishop, who's a very passionate district anaesthetist in KZN, and we would ask him to give us input on the anaesthetic side, for example. So we invited them to comment on different themes. So the one thing we asked people is everybody to give input. So if you had to teach them 5 or 6 topics, or you wanted them to look at 5 or 6 typical case things you want them to be able to manage in that area, what is important for them to know? First, to make sure we know what is the key guidelines and national protocols for those particular themes. And then do you know for cool webinars, resources, WhatsApp groups, tools? So it was a bit but it was very informally done. And we can certainly upgrade that process. So what we did with the program is it happened over 6 weeks. And I think next year I'm going to make it into an 8-week program. And then every week there was a theme for that week. So there was and then we would create resource packs. So I'll show you what those look like in a moment. And in the resource pack, it will be sort of saying to the young doctor, these are key stuff to look at. And this is some of the key resources you can use to look at those topics. And then we also organized weekly webinars. And I think partly because it is such a big field and there is so much to cover, we were quite enthusiastic, and I had 2 webinars a week. I will not do that again. I wasn't presenting, I was just doing all the Zoomy bits, but we got 12 amazing speakers to do 12 different topics over a 6 weeks period. And the expectation wasn't that the doctors are going to be, attending all 2 every week. We know what it's like. But as soon as you do that, you record all these things, and that's what becomes so extraordinary. So it's more like a recording studio. And I've seen on the YouTube, you'll have maybe 20 people that attend on the night, but you will see over the weeks and months following, I think David Bishop has already had over 230 views of his presentation. So this is just what the themes look like. So in week 1, we focused on infectious diseases. So we have a resource pack for HIV. There's one on TB and DRTB. And then there was one on non-HIV infectious diseases. So you'll have a bit on malaria and rabies and things like that. There's obviously a week on maternal health. There would be a week on non-communicable diseases, so particularly all your diabetics, cardiovascular, asthma, all of those things. And then we'll have other things that we would also add in, like the occupational health or some of the voice resources. Week 4, we do anaesthetics, trauma, and emergency medicine. You can see why I want to add an extra week. I think emergency medicine needs its own week. Child health pack specifically. And then in the last week, we were looking at mental health, patient-centered care, thriving in rural health systems. So I want to split those as well. So this is just to show you what would come in the email. So they'll get 2 or 3 emails in the week, and each email will be for a topic. Partly I sort it in such a way that it's easy for them to then later on find it. Okay, there's the HIV resource pack or whatever. And in the PDF, there would be links that they could go, and you can see we would have, these are all the main sort of topics that people thought everywhere, if you're not confident on managing postpartum hemorrhage, maybe you should go and watch Prof. Hofmeier's video, for example. Those are the key guidelines that we think they all need to at least know about or have access to. And then these were like webinars or additional resources that we would add. So this is a cool video you can watch on this. This is a good, excellent ESMO-E. The Tygerberg Hospital's got a very nice ESMO-E page. And these, of course, we can update and upgrade as time goes by. I'm sure all of you already think, oh, we should put that in, or oh, we should put this in. Please come and tell us so we can expand. And then also to make sure that all the stuff is in there is relevant for South Africa, relevant for a rural setting, and easily accessible. So then the webinar series was, as I said, it was, no, my maths, they are terrible. It was 12 webinars over 6 weeks, every Monday and Wednesday evening. People always ask what time. 5:30 seemed to work. I think 7 is too late for a lot of people. We didn't do it during work times. Because for some people, they already have their morning ward rounds that they need to get to. We find doing it later in the day during work time, people never get out of OPD to attend anything. So it was after hours. It was CPD accredited for people who attended the webinar. And we opened the webinars not only to people who signed up for the 6 weeks and was getting the resource packs, but anybody could join the webinars. We made those public webinars, and they were CPD accredited, so you would get a CPD certificate for attending. But not if you watch it later on YouTube. We need to work on that. And then we've got a Redasa YouTube channel, so all the webinars are there available. If you go to the right, of course, about this is that you don't just have to, it does not just guys who's doing the 6 weeks. It's available. 12 looked like during this year specifically. So for example, Dr. Mondondo, amazing DCST obstetrician, did a CTG interpretation one. Dr. Sean Gerati, she's a very passionate EMS specialist in PE, did one on triage in rural. We had some Prof. Parrish did some stuff on internal medicine emergencies. Hans Hendricks did a great series on orthopaedics. We send that to our interns in their first week in the district hospitals every rotation. Dave Bishop did the anaesthetics one. We had Lizelle Kiet did some amazing stuff on managing serious bacterial infections in infants. So an extraordinary range of different topics. And what's amazing is these are now available. So when I, for example, we were discussing diabetic ketoacidosis the other day, then I could just send the link to my young doctors and say, well, why don't you go and watch this? And then also we had a lovely talk on management of the aggressive patient by an amazing psychiatrist district team from Gauteng. So my biggest challenge is that this has been a one-way street. So I advertise it, all of us put together all these lovely resource packs, we do all these lovely webinars, and it goes out into the world, and I don't know what happens out there. So evaluating it has been a real challenge. So we did do polls during the actual feedbacks, and that feedback's always amazing. Wow, these are so useful, and these are so great, and so you get sort of little mini polls on the webinars. But then when I tried to do an evaluation survey to my 185 participants, I got 8 responses on the survey form, which was all very positive, but it doesn't really tell. And in terms of impact, it's all very low. The one thing what we have of having access to these resources, what we don't know is how much people are actually using these resources. And I've had some lovely people coming to tell me how useful they found this. But of course, that's a very biased view of what's happening out there. So strengths of this course has been the fact that it is widely accessible to any level clinician. So we've realized this is because anybody can tap in and do, I just want to update myself on maternal health, or I just need to sort out my emergency medicine skill levels. The structured weekly tasks, depending on personalities, help some of the doctors. So some of the doctors are quite keen to read, are quite keen to look up. You get some guys who actually does go home and open a textbook or want to watch a webinar. All the students just want the webinars. They don't want want to read. They just want the videos. But it's also depending on personality. So not everybody sits down and read. But for those people who do like to do a little bit, this helps to direct them. You know, what did I not know that I did not know? It's free. Cool, I'm almost there. And it's recorded and available throughout the year. So this is just to show you what the portal is going to look like. So we've got these very cool VIT students that's been given us as their project. It's very fun. We've been having little meetings with them, and they do us a website. And so you can see at the top there, it will have a rural onboarding. It will be behind a firewall, so you have to be a RHC member, which is free to access it. I'm very much inclusivity and access to all our materials. And then on the how to use section, I'll show you that in a minute. It just directs them, gives them a little program of those emails that I sent. So you'll go to HIV and TB, and it will lead you through what you can cover in HIV and TB with those resources and links, etc. And so how does it work? I want to divide it into 8 weeks, and we just advise them to go through the 8 weeks. What's also like medicine rotation, and I've sort of adapted this into a 24-week program. As you tell them, these are the 24 modules, and depending on what's happening in your rotation, you can decide which modules you're going to do. Are bringing you. So where we want to go with this, so CPD accreditation, we need to get clever with having it available, that possibility to see who's doing what out there. So you will have, usually the way one does online CPD stuff is that you have webinars they watch or things they read, and then you've got an MCQ that they need to complete, and if they get a certain amount of marks for the MCQ, they get a certain amount of CPD points. So we need to make sure that's fully automated, so that needs some discussion with my VIT students. It'll be lovely for this thing to be so we're very happy for RHC, RHC, PACASA. Well, PACASA actually very happily accesses the medical content as well. But to be able, this is just it's just a framework, so you can put anything in it, and you can very easily have. So, for example, we definitely going to invite Jillian to come to rural onboarding and do that presentation she did this morning, and our lovely presenter on the nursing is, that we want to add all of those things, but we can also add things that's specific then for your different sections. It needs quality assurance. So at the moment, I'm doing that as my role as WUSU. That means making sure that all the material that on there is up to date. When the HIV guidelines change, that you take off the old guidelines, that you take off webinars that are no longer relevant, etc. And then we have had a meeting last week with Kanile from the Community Service Committee in terms of placing community service. So they have committed, and they're very keen to actually place us on their invitation. When they when they tell all the consultants where they're going to go, to also tell them about the rural onboarding course. And I think that's going to really help us spread it over the provinces. And he wanted us to look at creating a knowledge hub version of that. And if we did that, then one can look a little bit more at a formal curriculum. And then lastly, my big dream in terms of really making something like this come together, and it's something that you'll hear me mention repeatedly, we just had it at the Congress, is this dream of having a family physician at every district hospital, at least in the country. And then you have the mentorship and the framework that within which rural boarding can sit. Because at the moment, it's just a bunch of material. But if you had somebody who can actually lead the program, can actually bring some of that things into the CPD meetings in the hospital in the week, somebody who's there to answer questions, then this program can really come to life. Thank you very much.
You've left 1 minute for a question. Anybody? Which I'll fill with a little story. In 1986, when we started in a rural hospital, I remember rushing home at lunchtime to have lunch and opening Harrison's textbook of medicine over the lunch table and looking up the patients that I had in my in my ward that I didn't know what the hell was going on. In fact, we had a little thing in the notes that Steve Knight started that says it was an abbreviation for I don't know what's going on here, which is really useful. I mean, if he didn't know, then nobody knew. So, that's right.
Is it on? Okay,
Yeah.
there we go. Just an idea about getting feedback. I'm thinking the intern supervisor at Worcester Hospital would love to have access to this, and she might be able to give you some feedback, and that might be a group of people that could use these resources usefully in terms of training interns.
Yeah. So we've already created this. So yeah, I use the same materials because I've got 6 months of family medicine interns, and I've created a 24-week roadmap, and like 8 modules for your district hospital rotation, 4 for your A&E rotation, 4 for you. So we've sort of divided it up, which I sent to Louis Jenkins. So I think it's already been distributed on the garden route. So yes, so I'm very happy for this stuff to just go out. Anybody who wants it can have it. And then all we want is people to join Radasa in terms of becoming part of the network to access materials. So we'll look at that. The intern program is slightly different, but we'll talk about that.
Thanks, Madeline. Excellent. Great presentation, and thank you for sticking to time. Our next presentation